Good afternoon. Happy Thursday. Happy Bowtie Thursday. This is Dr. Bill Bird. I'm the Chief Medical Officer here at CGH Medical Center. And if it looks like deja vu all over, it is. I have a couple of folks who are coming back to share some updates. So today I'm excited to have Dr. Eric Coons, who's the chairman of our Department of Medicine, with us to chat and answer some questions. And then after Dr. Coons is done, we have Dr. Eric Riley, who's the chairman for the Department of Surgery here as well. So welcome again, Eric.
Thank you.
Glad to have you again.
Always a pleasure.
Yeah. So, all right, let me get right at it, because I have quite a few questions that I want to throw at you here today, in addition to what other folks who are listening might have. So, first thing that kind of came to mind was vaccinations. And obviously we're waiting for this COVID vaccination, but right now there's been some stuff in the news about vaccinations for children and adults. So can you speak a little bit to that, what you're doing about that in the office? So kind of let's hear a little bit about that.
Right. Well, the American Academy of Pediatrics came out early on and said it is still important for kids to be on time with their immunizations. We don't want to create a second problem in trying to deal with the COVID problem. So we are prioritizing that those kids get in, they get their vaccinations, and they get protected, because when there's a delay, there's a time that they're not protected. And with some diseases like measles, we have to keep a very high rate of immunization to get herd immunity. There's been a lot talked about herd immunity, but with measles in particular, you got to keep it up like 95%. And if you do, it's good. But so that's important. We don't want to end up like some places in Minnesota that had outbreaks, and because we're otherwise trying to do the right thing.
Yeah.
The other big one is flu shots, and it's out of season for flu shots, so we don't have to go run out and get them now, and it's a little ways away. But it is an important point that the last thing we want this coming year is a bad flu season, right? If we have a bad flu season and we've got to figure out COVID and we've got to figure out which is which, that's kind of a disaster. Now, we wish flu shots were more effective than they are, but they do provide significant protection. People talk over here about between 40 and 60%,
right.
But that doesn't mean it's a coin flip. That's a 40 or 60% reduction. That's on the order of what seatbelts do for you. So it is a significant amount, and it's not only for you, right? If you get influenza,
So that's adding to the herd immunity.
Right. Well, yeah, the herd immunity is something that applies to influenza as well. If I gave you influenza, if I'd gotten my flu shot, you may have not gotten influenza. So for both of us, that's important. So yeah, immunizations remain a big deal, and when it comes time, we're going to twist people's arms a little harder this year yet to get the flu shot to make sure that we don't have both of those problems becoming big, because it's one big thing we can do to make sure this isn't a bad flu season coming.
Yeah. You know, it's interesting because it's ironic that we're desperately waiting for a vaccine for COVID.
Yes.
And yet,
yes.
we are so much hoping to get just the vaccines we already have,
right,
to get folks to get those.
Well, yeah, let me take a moment to talk about the COVID vaccine too, because there's a lot of interest in that.
Yeah.
And so one thing I think a lot of people don't realize is there isn't a vaccine. There's 15, 17 that are in development, and they're all trying to figure out what works the best and what's going to be the most effective. Some of them are a little further along in that process. Some of them are using really new technology, which is interesting and fascinating, and may allow things to go a little bit faster yet as well. But we're getting some instructions how to make sure we're doing this right.
Yeah. Last week we had the hand from below the table and pulled the mic down and did the adjustments. And this week I'm just the hand.
All right. You got to take care of.
Yeah.
So with the COVID vaccine, there's some promise that way. One of the ones that is one of these new technology vaccines has shown the ability to make appropriate antibodies, and so far in limited testing has been pretty safe. For people who have conspiracy theories about all the things that we're going to do with vaccines, there ones out there that we have, if it was really all about just getting them into everybody so we could get those microchips in and get people, tracked and all those sort of things, that would happen now when everybody's the most afraid. But what takes time is the safety testing, figuring out which one works well and which one's the safest out of among all these possibilities. And there may well be more than one vaccine that comes out. And when it does come out, I imagine it'll go to the highest risk people first, people who have the most to benefit, and there'll be some additional vetting there, so to speak. And when it's released to the general population, it'll be ready to go. And I imagine some of us will be among the first people to do it because, again, we have the most to gain, the most at risk.
Yeah.
But it is coming, and it is coming faster through overwhelming effort than I think is typical, and hopefully that continues.
Yeah. So, and I thought it's interesting too. It's one thing to develop it, which is really impressive, and to test it, and then just the idea of producing it, to not just mass producing it, is a big undertaking that I think folks even now, these companies are thinking out in terms of, okay, to have X number of millions of doses, how do we make that happen?
Right, and again, remember there's all these different technologies and they're made in different ways. So there's actually some facilities being set up in preparation to make different types of vaccines, knowing that some of them aren't going to get used or will have to be completely revamped to get used because they'll set up for the wrong one. But that if we set up multiple avenues when we get there, whichever one works out the best, it's ready to go and it's ready to scale up, because doing that quickly and getting to herd immunity takes a lot of vaccines. People talk about, we should let this run and get it to herd immunity. Well, that's a long ways away. I mean, even New York, which has been hardest hit, is maybe 20% of people.
And what's the herd immunity number that you've heard?
Well, I've heard between 60 and 80%. And so if you take those numbers, we'd have to have New York go through this 3 or 4 more times to get to herd immunity, and true herd immunity. Now there's shades of gray in between. You get a little bit more interruption in the disease spread for the more people that get it, but really getting safely to herd immunity requires a vaccine, and short of that, we'll have to deal with it at some level, and we just have to learn how to carefully live with and around this.
Yeah, good. Yeah, there was an article yesterday I wanted to talk about. It said about a third of Americans are currently anxious or depressed. And I guess what I'm wondering is, and that's more than usual. So the numbers are, I think in our lifetimes, about 20% of us, well, I forget if it's depression or anxiety or both, but about 20% of the population experiences that at some point in time in a lifetime. So 1/3 at one time is a pretty high number. And I'm just curious what you're seeing in your practice, and what you're doing in your practice, and then what ideas you might have beyond your practice for folks who might be listening or know someone who is listening, and what ideas that you had.
So this is a big deal, frankly. I mean, this is something that we really need to pay more attention to at multiple levels. And there are unintended consequences of trying to do the right thing sometimes. When we talk about social distancing, I'd really rather that be coined physical distancing, because we want to reach out socially to people. If people have a small unit of family, they're really isolated, and that takes a toll on people over time. And then people don't take care of themselves, and other health things happen from that. So I have seen this in the practice a fair amount, and I think some of it comes from anxiety over COVID in general. People who tend to be more wired tightly that way to begin with. This is really hard, in that they're very afraid. And I think it's important to know, as much as we want to be careful, there are ways that you can really reduce your risk and bring it down to a manageable level, especially in our area and community right now where we're doing pretty well. So it's still important to get out. It's important to take control of the things that you can, because a lot of anxiety comes from a sense of helplessness. I don't know what to do. I can't manage this. But if you set in place things that I'm taking care of myself, I'm getting my exercise, I'm eating well, I'm getting adequate sleep, and I'm engaging with people that are, that are the people that bring me up. I think those things are very helpful, and there is a time to reach out to us too. There's a time to say, I'm doing those right things, but I'm just not feeling like I'm getting there. I'm still really struggling. Medications aren't the first thing we go to, but there is a time where they help you get through a particularly difficult time, and this is that time for a lot of people. So please do reach out to us. That is a big part of what we're here for.
Yeah.
And we can even do a lot of that through telehealth. You don't even have to come in through that. So
yeah. So I'm going to go to, before I go to something else about mental health, just talking about the medications for it. What's your approach to giving patients, let's say they've done other things, counseling and exercise and all that kind of stuff, and you're still at the place where you're like, I think this patient could benefit from some medication. How do you decide antidepressant medication versus anti-anxiety medication, and how much of each and how long of each and all that type of stuff, just so folks get some idea of what a typical primary care doc's going to do with that.
Right. Well, we really try and break this down to what matters for you, and there's a lot. Some anti-anxiety medications tend to make you a little bit tired, and some people's depression gets expressed through I can't get out of bed. That's not the right medication for them. And then there's some people who they just can't sleep. They're wound all the time. They're afraid to go out to places. Those people do need a type of medication that kind of winds them down a little bit to find that sort of happy medium. And sometimes you have to approach that from both ends. And there's even a small group of people that have a lot of both, and we have to, based on the specific time, maybe use a small dose of one at a certain time and a small dose of another. Some of the anti-anxiety medications have the potential for some habit-forming, potential, and we need to respect that very carefully and take a good screening.
So that falls in the bucket of what's called benzodiazepines.
Right, primarily benzodiazepines. They work very rapidly. They're very helpful, but if people have had a tendency towards addictive behavior or those sort of things in the past, we got to be very, very careful with those. And say we never use them, but we're going to really keep a close eye on those sort of things. And we want to make sure primarily that they're used to make you functional. So if you would have gone out and done something, but your anxiety keeps you from doing that, if you can take a little bit of a medication to take the edge off of that and then go do the thing, that's encouraging. If you're hunkered down at home and you're feeling sad and you want to drown your sorrows, that's a problem. So we just have to make sure we're using them really carefully and appropriately.
Yeah, good. And so, in the community there are definitely other resources for mental health. Can you kind of speak to how you use those and how you, if people wanted to access those, what options they have?
Yeah, and this is, thank you for bringing that up, because there's a big piece of this that we haven't addressed yet. Counseling is really important, and we do have several facilities and people that do counseling, some both internal to the clinic and hospital structure and external to that. But counseling gives you tools. So when you can practice how to do things so that when you get into that situation, you have a tool or a method to help you get through that situation. And that's really the best long term. So that's a really important part of this as well, that we use quite a bit. We do recommend a lot of counseling. For me, it's a little bit like, when you get injured, you take pain medications, but a lot of times you need physical therapy to rehab yourself too.
Yeah.
And counseling is that sort of long-term, I'm going to figure out how to do this better so I don't need medications, at least at the same level in the future, or maybe not at all. And that should always be our goal, is to do this the best we can through building tools in your own tool set.
Yeah, so we're talking Sinisippi.
Right.
We're talking the health department.
Mm-hmm.
And through Sinisippi, we have Ways to Wellness through Christine, who's been on this Facebook Live before in the past. So we have multiple options of places for people to access services,
Right.
if they're having those kind of symptoms.
Right. And this applies to all different insurance and coverage types. That there is at least something available. So
yeah, okay, good. One of the things that I wanted to chat with you about too is I'm reading, and I'm experiencing this in my own family, is I think the number was 48% of Americans have delayed medical care due to COVID concerns. And that concerns me now that we're 2.5 months into this.
Yeah.
Yeah, so what are you seeing in your practice, and what would you say about this, and what are you doing about this?
Yeah, we're definitely seeing this, and some of it was even what we asked people to do, because we needed to reschedule some stuff to have some time to figure this out, make sure we're doing it more safely, and spread appointments out a little bit. But moving forward, that should become less and less, and delaying a routine physical or a yearly check, has a fairly low risk if it's for a fairly short period of time, but that risk starts to add up over time, that things are getting more and more out of control. We've all had patients that have been kind of lost to follow-up, as we put it, for a while, and they come back and their diabetes is out of control, now they're losing a toe, or worse. And the other half of that, the one that I really want to stress, is the people who have an injury or a symptom of something major that they're afraid to go into the hospital. They have stroke symptoms, they have chest pain, they have all those sort of things. I can't stress this enough, that your greater risk is in waiting those out. We can manage these things and address these things and check out these things safely here at this point. I think it's just critical that people get comfortable with seeking care when they need it. We've really paid a lot of attention to doing this right. Let us help now, and don't let it wait until you're much sicker or something bad has already happened.
Yeah, and we are starting to see a bit of an uptick in the ED, so I think folks are beginning to feel more comfortable with coming in for those things, and that is really good. I saw something else, I think it was today or yesterday, that the amount of people diagnosed with colon cancer went down by 1/3 in March and April.
Yeah, those cases, those.
And it's not that those people aren't, there's a 1/3 less colon cancer.
No, exactly. We know that statistically that is a steady thing. So essentially we've missed those 1/3. Hopefully we'll come back and get them before it goes much further, but in the cases of cancer, delays cost lives, they cost quality of life, all those sort of things. So yes, we very much need to get back at that stuff, because a little delay is one thing, but when we're starting to get into this further, we have to learn to live with this, balancing all of those things.
Yeah.
Well.
Yeah. So anyhow, for those of you listening, and if you have screening tests that you've been putting off, please get them back on your schedule and get those taken care of. So, hot topic is antibody testing still.
Yeah.
So here's where I'm going with this. So, what do we know about the accuracy of the test? What do we know about the value of the test? When are they of value? And what are we doing here at CGH with antibody testing?
Right. Okay. So the accuracy of the test, early on it was a disaster, because in an effort to get more tests out quickly, the FDA kind of lowered all of the standards as far as what needs to be. So everybody, with the lab, seems like they could have developed their own tests. These tests are relatively easy to develop at some level, but they didn't. A lot of them picked up other forms of coronaviruses that don't matter here, and it was really a disaster. The FDA has clamped down some, and the newer tests are better, but there's a particular thing here with individual testing. I'll get back to that just in a moment. For population testing, it can be interesting to say this population has this much rate of this many people have had COVID. For that, it's pretty useful. But in the individual, it's an important thing. And this gets into a little statistics, but I'm going to try and break this down in very simple, people-friendly measures here. So first, what matters, right? What people want to know is, did I have this in the past? A positive test. If it's a negative test, well, then it's the same as it always was. Nothing changes. You still got to be careful. It's the positive tests that people will say, I think I had some symptoms. I want to know if this was COVID. So that each test has an error rate, and we won't get into all the names for that. But let's say there's a 5% of those in a particular test, 5% of those tests are false positives. And that's probably pretty true for a lot of the tests that are out there right now. Some of them are getting a little bit better than that, but for an easy to work with number, let's say it's 5%. Now, let's say in your community, 5% of the people have had COVID. That's probably high here. We're probably nowhere near that in this area. But for making this an easy comparison,
to make a point, yeah.
let's say 5% of people in this community have had it, okay? So out of 100 people, you take 100 people, you send them all in to get a test. We know, because 5% of the people have it, 5 of those people should get a true positive test. They've actually had it, they've got a true positive test. But we also know that for every 100 people, even with 95% accuracy, there's 5 people who are going to get a false positive.
So I'm saying 5 and 5.
5, right. So in areas that COVID isn't very common, that test is as likely to give you a bad result as a positive result.
So in bad positive.
Yeah, and then what do you do with the positive result? You're like, oh, I'm good. I don't need a hand wash. I don't need to wear a mask. I can go, out and
so half
go
the
to
people, half the people that have that test go la-di-da, off I go, and they're walking into harm's way.
Right. So for that reason, we're not doing antibody tests here right now, because in order for a test to be useful, it has to give me results that I can say I'm comfortable acting on these. When a test is in our particular situation, now this may not be the case everywhere, but in our particular situation, that test is probably as likely to give me a false positive as a true positive, just because our rates are pretty low here.
Yeah.
Then I don't think that's a particularly useful test. So I'm really discouraging people from doing that. I understand the want. I would,
Sure.
I had a little scratchy throat really in the ear. It kind of, it makes you wonder sometimes. But I don't want to say, oh, I'm good, and then expose people out of a false sense of security here.
Yeah, good. So I tend to ask you this when you've come on before, because you're in charge of our COVID clinical team. But anything new in terms of treatments for patients with COVID here at CGH?
Well, I've been excited. Now, this is very anecdotal, but we've had some good results with the convalescent plasma, and it's exciting to be a part of that. So that part's been exciting. We're looking at remdesivir as well, but there's, one of the things that we've seen a lot of, and I think it's really caused a lot of trouble on social media, is everybody wants to get information out so quickly that it's not very well vetted, and we're not doing things in the careful way that we normally do. So there's a lot of information that gets out there prematurely. People get whiplash about one thing that's said, another thing that's said.
Yeah.
Normally, these small studies would just be something that say, hey, that's interesting, let's study this for real, and it never really gets out into the public until we've taken more time to vet this. Remdesivir is interesting and promising, but not yet proven that it in a very rigorous way. So there was just an article released today in the New England Journal
I
of
saw
Medicine,
that, yeah.
comparing a 5-day and a 10-day course, and it said the 5-day, if it was an interesting little thing. They said, if remdesivir is helpful, a 5-day course is as good as a 10-day course. Okay, well, at least they're being very specific about what they're claiming there. But even the New England Journal of Medicine isn't saying, yeah, we're really sure about that. So it's promising that it may be of some use, but we're really cautious about safety data, so it remains under review there. We're also doing a lot as far as just how do we manage these patients, having these patients, and we talked about this a little bit last time, but prone positioning. People really seem to do better. Tolerating and letting people tolerate some level of low oxygen without intubating them is early. Those sort of things that are things, approaches that we're looking at and managing, and so it's definitely interesting and evolving.
Yeah, I think and also with remdesivir, over time we'll figure it out. Like for those listening, Tamiflu's been out for a long time, and we know that Tamiflu, you typically need to start it pretty quick, or it's not going to do much for you.
Mm-hmm.
Is remdesivir going to fall in that bucket, or is it going to fall in the bucket of, oh, it's better when you get really sick to take? And
Yeah.
so we don't know that. We're still working on through those things, from what I understand.
Right. It's something that it's hard, but it's still important to do science and medicine carefully and right. Here, so
Yeah.
we're looking at it closely, but it remains to be
Yeah.
fully vetted here.
Good. Yeah, and I just wanted to, just curious about how we're kind of beginning to we're continuing to doing it properly. We're trying to ramp up in our offices. So
Mhm.
how's that process going for your office?
Good. What I like to see is we've really established a lot of attention to detail. We have processes in place where we're really careful about things. The level of cleaning that goes into between each visit, and making sure we're scheduling patients carefully and not having them bunch up in waiting rooms and stuff like that. That makes a big impact here. So I think it's going well. We are not up to full speed, but we're getting closer, and I'm comfortable with how the process is going. It's one of the things I love about being in a small town, right? People have done a really good job about understanding having to work around this, and I can't say that I appreciate that enough. It's just wonderful that people are very helpful and flexible about those sort of things. They're adapting to telehealth when it's reasonable, and so there's a lot of things that are really going well, and I'm really happy with when I walk around this place, both the clinic and the hospital, the level of consistent attention to detail to those things, because it's very easy to get complacent, and we're just not going to allow that here.
Yeah. Yeah, for sure. And that's part of the culture we're working on very
Right.
hard. I mentioned this last week about this article that Atul Gawande put together, and it talks about these 4 pillars, and they are hygiene, distancing, screening, and masking, and we are holding steady to those.
Mm-hmm. Yeah, it's a great article, and if you, just as an aside,
We'll put it in if you look
Yeah.
on our Facebook page, we'll reference it. It's a really interesting read. It's about 10-15 minute
right.
read.
He's a great author in general about all things in medicine, and often challenging medicine in very constructive ways. But
Yeah.
So anyway, please link that, because if you have time, if you're still in quarantine, read a few books by him. They're worthwhile.
Yeah, exactly. Nursing home patients. So talk a little bit about, you have some nursing home patients. What's your process right now to try to take care of those folks and also understand the situation going on in those nursing facilities?
Right. Well, some of it we're able to do through telehealth, which is helpful. And then there are times that we just we go through and we're careful about doing everything correctly as far as washing between patients and wearing masks and doing all those sort of things. But we still have to take care of them. And if there's a population that my heart bleeds for as much as any, it's our nursing home population. They're at risk, and the things we have to do to minimize that risk are hard. So we very much still need to reach out and take care of our nursing home population. If I could say one more thing about masks, because that's been a really hot topic too, right? And there's been a lot of debate, and there aren't great studies to say in the hands of the average Joe that masking is always beneficial, but we know if it's done right, it significantly reduces the risk.
Yeah.
And I see a lot of it not being done right. A lot of people out in the community, touching their mask a lot, and it happens, but at least hand sanitize if you do that. And I see a lot of people wearing their mask below their nose, and to me that's like wearing your underwear too low. It's just not doing its job right there, right? So if I can fix that picture in your head, so you
I
don't
haven't
do
heard
that.
that one before. I think we might end with that analogy. That's a way to bring it on home.
All
there,
right,
but,
so keep your mask up. All right.
So if in another life, I think Dr. Coons was probably a professor, because he does a really good job of taking complex things and making them more simple to understand. And so, Eric, I thank you again for taking the time and showing up and being part of this process.
Well, thanks for the opportunity.
Yeah, thank you. Now we're going to take your chair out,
Yep.
and pull another chair in.
Sanitize.
Oh, yes, all the proper precautions. Hi, Dr. Riley.
Hi, how we doing?
Good, looking sharp today.
Yeah, you as well on your bow tie?
Yes, yes, bow tie Thursday, bow tie Thursday. So, I have a couple questions that I have from Dana, and I will make sure to get to those before we're done here today. But I wanted to have a number of questions that I wanted to run by Dr. Riley. So, and by the way, Dr. Riley is the chairman for our surgical department. So he oversees all the procedural, in general, all the procedural based stuff here at the hospital. So, yeah, Eric, how are we at in the process of like ramping up stuff happening in the OR?
Well, we're happy to be back at work, number one, which is great, because as surgeons we love to get our hands dirty, and we certainly are happy to be back at work doing all elective procedures as well as urgent emergent procedures. We've been meeting weekly. We developed a plan whereby we ramped up slowly, and effectively we're in phase 2 as of right now, which is effectively 2/3 of the pre-pandemic volume for the surgeons at this time. We anticipate we'll be there for another week, and I believe the week of June 8th we should be pretty close to being back to full speed.
Yeah.
And that is for elective procedures.
Right, so and then the urgent emergent things, they keep happening. If you come in and have broken a bone that needs set, or
Correct.
those kind of things.
Yeah, those things have been going on.
Yeah, good. Where are we at with backlog procedures? People that had, prior to the pandemic, had planned to have something done, and where are we at with that?
Well, fortunately, folks have been very, very patient, which has been great. There has been a backlog as a result of the cases that were already scheduled and not being able to be done. Those are being handled, when each practice and each surgeon is handling those a bit differently. At last check, everybody, from my understanding, has been able to reschedule most of those patients, and they're on the books, ready to go. We're not too far off. I think we're maybe a month or two out in terms of some of those procedures being done. With the time frame of which, being a proceduralist, you have to be in the office to try and find people to help, or find it.
You don't find people walking around the street and say, "Hey,
Right.
look, that was
Right.
like a button in there."
Well, you do, but certainly. I wish it was that easy. But a chance to be in the clinic to find people, that you can help surgically, and without being in the clinic, of course, we've not had that uptick. So the backlog hasn't seemed to be as big of a problem for us as we thought it was going to be.
Okay. So we talked about this last time you were here, but I want to go through it again, just so folks understand how much we're working to make sure that this is a very safe process for them. So what is being done from the time a patient gets to the hospital until they're discharged from the hospital to make sure that they're safe?
Sure. Well, safety is at utmost concern, certainly for everyone, and surgical patients are no different in that. And so what we've tried to do is to pre-screen, or to pre-register patients rather than having them come in and meet with admitting and having multiple points of contact. So we really try to minimize that, pre-registering as many patients as we possibly can. From that, as with any patient that comes into the hospital, again, we're on visitor restrictions, so family is not allowed to come in, and the patient would then come to the door. They're screened of their symptoms, temperature. They're then masked and then escorted to the surgical area, providing that they've been pre-registered.
Yeah.
Within the surgical area, of course, we have, at CGH, we're very fortunate in our ambulatory surgery unit, and that's where all surgical patients come to have private rooms. And so the interaction with multiple points of contact are very minimal at best.
Yeah, I was just down there this morning, and man, they have it down. I mean, they have everything so that everyone is just in their rooms, and then they go right to the OR. And
Correct, and very little contact would happen with any extraneous individuals, and then they're taken from their room at ASU. They would go back, have their operation. From there, taken to the recovery unit and or right back to their room, to which then they're discharged directly from their room.
yeah, and also I wanted you to just kind of speak a little bit. There's the OR area, and then there's if you're going to be admitted to the hospital after your surgery, there's a surgical floor. Can you speak a little bit to what the rhythm is right there right now and how things are going there?
Sure. Our surgical floor is fully up and running. Again, safety being of utmost importance. For our surgical patients, again, all of our rooms are private, and so again, no real cross-contamination is really occurring. For anybody who was at risk for COVID, whether it be under investigation, awaiting those tests to come back, and or a known positive patients, we have those patients in isolation. And they're completely separate from that of a surgical patient.
Good. So talk a little bit, so we have these rapid COVID tests now. We have a limited number of them, but we have some rapid COVID tests that gives us the information within, I think, 90 minutes or so. How are we using those for surgeries?
Well, I would like to say it's revolutionized things, but because of the limited number, of course, and the lack of resources, it hasn't changed the game all that much. Although the beauty in this is that we know now through this rapid testing that every patient that comes into the operating room, we know, barring a absolute life-saving procedure where we just don't have time to get the test, which is a very, very rare situation. But without that, we know every patient is either positive or negative. And that's really helped us in terms of delegation of our resources. And if it is an elective procedure, for example, and the patient was positive, that case would then be rescheduled to allow that patient to recover.
Yeah, so I didn't even ask this. We talked about it last time. So what is that process for elective procedures again for COVID testing?
So for COVID testing, every patient is required to have a test, and that test would be done at our reference lab. We're doing those, I believe we're still doing those at ReadyCare, and those patients are then known as to whether or not within 72-hour window as to whether or not they have been exposed or positive. If they are, the case would then be canceled, rescheduled to allow that patient to self-quarantine and recover, hopefully donate convalescent plasma thereafter if possible, and then come back at a more appropriate time where they'd be retested to make sure that they're negative. And again, the window is 72 hours prior to your procedure that you would have to have that test.
Right, and we're asking folks during the time they're tested, at the time of surgery, to quarantine at home and those type of things too.
Right, yeah.
Okay, so rubber hits the road. Are there any patients, I'm just going to throw it out at you, are there any patients that right now you're recommending to not have surgery at this time due to COVID concerns?
Absolutely not. If you have a surgical problem, there's absolutely no reason why you shouldn't have an operation.
Okay.
Especially here at CGH.
I just wanted to throw that out there because I know that there's a lot of people who have those kind of questions, and yeah, very that's a pretty simple answer.
Absolutely not.
Yeah, I didn't think so, but I wanted to ask. All right, and I wanted to just, since we have you here, I wanted to ask you just some stuff, since we're kind of talking safety and all that stuff for our patients. There are some things that happen in the OR that I don't know that folks are aware of that take place in addition to the stuff that we're doing now for COVID that we do to make sure that they're safe. So I'm gonna throw a couple things out at you, and I just want you to speak to these if you would for me. So can you talk about the timeout process and how that works?
Sure.
It's not like a little kid where you say you have timeout.
No. But the timeout process is a national standard by which everybody follows, and regardless of any procedure, whether it be done in the operating room or in the clinic setting, because this happens in the clinic setting as well, for invasive type procedures, is a process by which we have we recognize the correct patient, the correct procedure, and then the correct site, whether it be site and or side. Speaking of, we call it laterality, and laterality meaning right or left, and then the appropriate site.
Okay. So, and I'm wondering, in your career, did you start out with that in your career?
Yeah.
Okay, so
It's
you're
always
not
been a part.
you're not pre-timeout guy.
No.
Okay, because I remember back in the day that was a big conversation about this, and
It is, and unfortunately, even despite it, it still has its drawbacks. Even though we're doing these things, and for not at CGH, but certainly this happens nationwide, where there is some flaws in that system.
yeah. And then I wanted to ask a little bit about antibiotics. So we're trying not to use any more antibiotics than we need to. You're trying to be good stewards about that. We actually have an antibiotic stewardship committee because of national issues with that. But we use those antibiotics for some surgical patients, and I wanted just to kind of you to speak to who gets them, when do they get them, why do they get them, and what do we have in place to make sure they get them the way that we want them to get them.
Sure.
That's
Well,
a lot of questions at once, but I know you're good for it.
It's a broad topic, it really is, and it holds a fair amount of controversy just amidst the medical community and then society at large, really. And they're absolutely necessary, and so it's really surgeon dependent. National standard or guidelines that would dictate whether or not an antibiotic absolutely has to be used. It is provider or surgeon dependent. And procedure dependent, and if those are chosen, and prophylaxis as far as trying to prevent that of infection, we make sure that those are given at the appropriate time, and the time is generally 30 to 60 minutes prior to the procedure itself. And so it's timed appropriately, it's appropriately utilized, and then again made sure that it's given accurately through that timeout process, because that is part of the process.
And our surgeons all have these what you call a power plan or whatever you want to call it. They have a set protocol of what happens, and so that makes sure that our staff know exactly when and all those type of things too. So. I don't know if you were here, Eric, when Eric Coons and I were talking about people putting off stuff medically. And I think the number is like close to 50%. And I wanted to pick your brain about something that in your practice that I'm wondering if you can just speak to. So as a podiatrist as well as a wound center physician, Dr. Riley goes as well to see patients. Can you speak to the need for diabetic patients to make sure they don't neglect their feet during this time, or if they are supposed to follow up for those kind of things? And
sure, I mean that's a population of which I could think that may put things off, and it's difficult because those are the folks that are the sickest and probably of utmost importance, of which are closely surveilled and seen on a routine basis. They often forget that and neglect that. Unfortunately, they may or may not have had a bad outcome, and even despite that bad outcome, still kind of tend to neglect that. But that population in particular are the ones that should not put anything off. It could be, I've been told sometimes not to be scary, but in a diabetic, I mean, it certainly can be a blister in the morning, and we could be doing something in the operating room where folks are not going to have a good outcome because the fact that they neglected something that didn't look like a big deal. So that population in particular is...
Yeah, so if they have an appointment for you for that, they definitely need to...
Sure.
Yeah, okay. All right, well, let's see what I have here for questions. Okay, so I have a couple questions for the professor when we get done here. But I have one that's about, it falls under your bucket, Eric Riley, A couple of people have asked about visitors, particularly for like labor and delivery, and
So we have not, we are still allowing family in for that. To
Yeah,
my
one
understanding.
support person.
One support individual can come in for that particular. Now, nationwide, there have been institutions that have disallowed that, but we have not. We've not
Yeah.
done so. And to that end, similar but different vein would be our pediatric population as well, as far as peds cases that are going on. Again, a support person is here, guardians are here for them.
yeah, yeah, and also I think and I know there's another category for folks who have some type of disability that they need a caregiver. Then we're letting those folks in too. And the question, I think the theme of the questions that I'm getting is when are you going to loosen up on your visitor policy to let folks come in and be support people for someone who's having surgery or who's here and has some medical condition? And those are fair questions, they really are. Right now, we are in the process of evaluating that every week, and we're kind of, as the state gives, we're trying to kind of follow that. The state gives guidance in terms of, what they're recommending, what phase we're in for healthcare, and so we're going to try our best to kind of mirror what they're saying there. So, yeah, I hope that here in the near future we can begin to have more folks come in, but we're going to be measured in that, and understand that, it's all about safety, and in that spirit, the more people you have around, and you can't do the social distance. We have it set up very nicely for social distancing right now, but you start doubling up on the number of people that are here, and that gets harder to make it happen. And I don't want to be some other place in our community, and I watch this process and I cringe. I don't want to be cringe-worthy here at the hospital. So there is that going on in terms of we're thinking it through. Right now, it's one person in OB and some of these other categories, and otherwise we're trying to, So, but a fair question nonetheless. Okay. 2 other questions. So in another life, what do you think you would have been, Eric? What were you going to do before you decided that you wanted to go into podiatry?
Wow. That's an interesting. Personal story.
I'll take it.
I was finishing up undergrad and found the love of my life and became engaged. My father-in-law will love this story, so if he's watching, Tom, this is for you. But nonetheless, I felt it very important that I was called to have a job to provide for my wife, and I'll never forget asking for her hand in marriage. Was scared to death, and he said, "Well, how are you going to provide for my daughter?" And I said, "Well, this is great because I already have a job lined up, and this is perfect." And I had, was going to go out into surgical sales and do that, and so it was good. And he did not ask me how long I had to keep the job, because we went on an engaged encounter and then learned a lot about ourselves, and she said that she wasn't going to marry me unless I went after my dream, and that was to be a provider. And
Okay.
I've asked her, 13 years later, are you sure you really wanted me to do that?
And the response is that, and she's
resounding yes.
all right, good.
So
That's a good story.
I was destined to be a surgical salesman. I was certainly not wanting to do that. It didn't last very long. I did not keep that job very long. But I also had considered a financial analyst.
Okay,
So.
good. All right. And what is your favorite surgery and why?
Oh boy, they're all good. A good day in surgery doesn't beat a bad day in clinic. Or a bad day in surgery doesn't beat a good day.
That's spoken like a true surgeon. Yes.
So yeah, boy, I will say I love instant gratification, and in the outpatient setting, we do a lot of in-office procedures, and believe it or not, ingrown toenail surgery is one of my favorites, because
Really?
you come in and if anyone's ever had one, you're just
Mhm.
absolutely, frankly miserable.
Yeah.
And when you leave my office, you're asymptomatic, you're pain-free. So in the outpatient setting, it would be that. In the more surgical realm, in terms of the operating room, I would probably say trauma. And ankle fractures, for example, comes up. Patients come in and they're mangled, and we get an opportunity to put them back together. And again, it's very humbling that patients trust you to do that, and they come in deformed and mangled, and you're able to put them back together and set them up for what you hope to be a good outcome for those patients,
Yeah.
if they listen, of course.
Good, good.
So,
Thank you so much for your
Yeah,
time. Appreciate it.
absolutely.
Appreciate
No
it. Yeah,
I'll
thank you
take
very
my
much.
chair and
Take your
exit the
chair,
seat.
and then I'm gonna have the professor roll his chair this way. And okay, I've got. Let's see here.
Thanks for the new title, Bill.
That's nice.
I've given you a PhD. Let's see here. Let's see here. Here's one for us. Okay. People say the mask interferes with their O2 and CO2 levels.
Yeah, so like I said, it's the thing that I'm seeing all over on Facebook is a lot of worry about the mask. And one of the things to point out is this, if there's anything that we're expert in how you feel and how you do, it's wearing masks. Probably even should have asked the surgeon that Dr. Riley wears a mask for hours at a time and puts people's feet back together after they've been crushed. So does it make a difference? Yes. Kind of this big in terms of actual numbers. When people in my office are afraid about, well, can't this possibly do that, or my lab result is abnormal, and I say, yeah, but your lab result is, in terms of speeding, it's doing 57 and a 55. It's really kind of okay. Yeah. And the same thing applies here. Does that change a little bit? It does, and it's not to say that you might even not feel that to a degree. And I want to be sympathetic for people who, have a lot of claustrophobia. It can be very difficult. I'm not saying that it isn't hard. I don't love wearing the mask all the time. I like to take it off when I can safely do so. But in terms of, is this a risk for you? Are you going to have a bad health outcome because you're wearing a mask? Clearly, no. People do brain surgery, or Dr. King here does vascular surgery for 12 or 14 hours, and he performs as well at the 12th hour as he does, early on that way. It is okay, and it is safe. Is it annoying sometimes? Absolutely.
Mm-hmm.
But is it safe? Yes.
Yeah, good. Thank you. And then I have one here. Let's see here. Unsure when an immunocompromised patient should feel comfortable to go out with appropriate precautions for routine, like dental fillings, medical care, haircut.
Yeah. So there's a whole level of risk stratification, and they bring up a lot of very important things. When it comes to level of risk, it's how long you're exposed, how close you're exposed, and how many people. So things that seem somewhat benign. I don't want to pick on people who are in a particular industry, but places that you have to be especially careful about are things that have prolonged exposure, and getting a haircut is kind of one of those. I mean, they're standing right over you, right next to you for an hour, so you want to be particularly careful about that. I'm not saying you can't ever do that, but you want to make sure that everybody's wearing a mask. You're not doing that more often than you really have to. Same sort of thing applies to dentists a little bit, because they're kind of right up in, very close. So those things are higher risk. Now, your dental care is important not only for your dental health, but for your general health too. So at some point you've got to take that risk, and you just make sure everybody's at the top of their game when they do that. Now, as far as coming here, your encounters here are generally fairly brief. We're very, very careful about that. I think even for an immunocompromised person, kind of like Dr. Wiley said, is there a person at this point who should not come into the office, full stop? That is not the case. I think anybody can come into the office. There are certain people who are high risk that we would rather that they not go out at all, and if it can be accomplished through telehealth, we'd still prefer that. But if you have something where we need to lay hands on you, you should definitely feel comfortable doing that. As far as other more minor, things you should do, getting outside, boy, you absolutely should get outside. It's a beautiful time of year. It's good for your health. Part of keeping up your wellness in the COVID time is making sure you're staying fit. You're doing those sort of things, and people get afraid to go outside, and that much is a shame. Were there any other specific circumstances?
I think that was the main ones, and I think I can speak to. I know that my wife got something from her stylist, and they have a pretty stuff they're having to follow, and dental folks have their societies, and so I hear what you're saying. I think folks are doing everything they can, and the state is being pretty clear, and we have I would say a fairly conservative state in terms of what we're safety is a pretty high priority in terms of what.
So practically speaking, ways you might manage that risk is maybe I just get my hair cut and I don't get the full coloring and the stuff like that. And also interesting things, blow dryers. They're kind of a big deal in that situation. So maybe you get your hair. I know our hairstylist has brought up that we're not going to be doing that. So we're gonna cut your hair and we're gonna do those sort of things, but we're going to be limiting stuff that is higher risk. So there are ways that you can still get the essentials done, but maybe. Maybe the highlights you can wait till later.
I don't know. My highlights are really important to me. I don't know that I want to wait too long. You can see what's happening here. I haven't done highlights for the last 2.5 months, and here I am. All right. So this was just kind of a question about appointment for a cardiologist. Haven't done the blood work yet. Appointment was due April 1st. It was pushed back. Is it going to be really crazy now that everything is opened up to go in for that cardiology appointment?
We're not going to let things get crazy. All right. No. There might still be some degree of delays, but we're going to be very careful about not letting things get crazy. And as we get busier, we may have to implement things like we're looking into: is there a way that people wait in their car for a little while rather than come into the waiting room? Those are all things we're thinking about, and it depends on how things are all going, but we will not let things get crazy here.
Right, and I can tell you that on the cardiology side of things, they definitely have room in their schedules to get folks in still, and so I don't think that should be an issue. And whoever sent that out, I'd just encourage you to make sure you do that.
Yeah.
And one more question as our time's about out. There was a question about the flu shot, and what does it say? How soon, when should you get your flu shot, and how long does it last?
So the flu shot does have a curve as far as how effective it is, and it's always a little bit if it looks like it's coming really soon, trying to get it earlier. A little bit is paying attention to the news and what's coming, but in general, I like to have my patients try and have it by October, because I'd rather have them have it a little bit too soon than a day too late, because being a little less effective later is less important than being not effective at all because you missed it. So October is usually a pretty good date to make sure you have it.
Yeah, and there is something to be said for timing, because I think I've read where it's about 10% a month of so you get the shot within a week or two, your immunity is in pretty decent shape, and then your immunity degrades about 10% every month thereafter, and then I think if I remember right, it's 6 to 9 months that they would say you have some level of protection from that shot.
Right. I do get a little nervous when I see some of their big chain pharmacies starting to advertise it like at the end of July or August. It's like, geez, and
if you do the math on that 10% a month,
yeah.
You start getting into January or February.
Right.
And we've seen flu as late as April.
Yeah. So I think erring on the side of caution, but still being practical is towards the fall.
Yeah.
Not
Okay.
summer.
Good. Thank you. Appreciate
right.
the follow-up questions. Thanks everyone for listening. Have a great week.